So we'll pick up where we left off before. We were just starting to talk about the roots of the meniscus. And here we can see the root attachment of the posterior horn of the medial. We're just catching a little bit of the anterior attachment of the lateral. And then if we go anteriorly, here we can see the anterior horn attachment of the lateral, and more anteriorly we can see the anterior horn attachment of the medial. Okay, so Jennifer, what do you think of this case?
I can see the attachment of the posterior root of the lateral meniscus. We're catching it at an angle there, so I'd have to follow it back to make sure it's in continuity, but I don't see a tear. And then the posterior root of the medial meniscus, I can see it touching down there to the tibia, so
Okay.
I don't think that there's a tear there either.
Good. Okay, so this is a lower field scanner, and let me just, can't find my cursor here. What am I going to do with it? Wrong screen. There we go. Okay, and then so we can see on the medial side, there's the posterior root attachment. So this was on 11/10/2003. On the sagittal image, we can follow the dark meniscal attachment all the way down to bone. So the patient was injured again in 2005, 2.5 years later, and this is what it looked like. What'd you find, Jennifer?
So now I can see there that there's increased fluid signal intensity at the posterior root of the medial meniscus, and that's suspicious for a tear.
Yeah, and we can see that there's a injury to the bone here as well. And if we go to the sagittal images, we can't follow that dark signal of the meniscus all the way down to the bone. So this was a tear of the posterior root attachment of the medial meniscus. And we'll look at an arthroscopic video in a minute. This is the femoral condyle up here. Here's the meniscus here. Here's the tibial plateau. And what we'll do is we'll follow the meniscus around. This is a nice normal free edge of the meniscus. And then we'll get to the back and we'll see where it's torn off its attachment to the tibia right here. So here's the video. And you can see the nice free edge there kind of flapping in the breeze. And when you get back to the back, you can see where it's been torn off the tibial attachment. You can see some blood there at the attachment and see how unstable it is. So that's an acute posterior root tear, and we can see the MR scan before the injury and then the MR scan after the injury. Okay. And we know that they're associated with poor outcomes by a couple of different studies. And we'll see some orthopedic studies later to show that the outcome in patients is much better if you do a primary repair than if you leave these alone. Because again, this completely disrupts the hoop fibers that we were talking about before. The meniscus extrudes, and it's like not having a meniscus at all. It no longer stabilizes the knee and leads to increased wear and tear on the articular cartilage and increased strain on the anterior cruciate ligament. Okay, let's see here. Michael, what do you think of this one?
Okay, so on coronal views at the knee, it looks like there's a posterior root tear of the medial meniscus. And the lateral meniscus, I can't follow it to its root, but it looks it's okay. Mm-hmm.
Okay, so we have a root tear of the medial meniscus right.
Was there? If we could go back, that's not a. Is that a bony signal? And so it looks like there's an avulsion as well.
So this is a root avulsion. You can see the bone has been avulsed off along the root there. Typically, tissue and bone on them that get pulled off like that, they tend to heal better than if the bone doesn't come off. Because if you put it back again, the bone tends to heal very well, but the soft tissue and bone don't heal as well. And if you look here, here's that posterior horn of the medial meniscus, but if we follow it back over to the tibia, we can see the area of the tear. So, so this is another medial root tear. Okay, Ashu, what do you think of this one?
Okay, so we're looking at the posterior roots here. I'm looking at the PDF that's that. On the right, I think I see the fibers of the posterior root of the lateral meniscus. Okay, going up there, but don't really see the medial meniscus very well at the posterior root. If it's going all the way to the tibia, I don't really see it. There seems to be some signal there as well.
So what this is another bony avulsion.
Okay.
This is where the bone cracked and a little piece of bone was pulled off, and there's the menisco-tibial attachment. It's just that the little piece of tibia is no longer attached to the tibia. So this is another root avulsion. And then this patient then had surgery, which we can see. And, here on the sagittal images, we can see that that little piece of bone is pulled off with the meniscus. The patient has an ACL. And this was another root avulsion. Okay. There's a 64-year-old female with post-traumatic knee pain, 12909. Here we can see a root tear right here at the posterior root attachment of the medial meniscus. And here we had a lot of metal artifact in that location. After I tried to do a primary repair of the root. And then, so that was a root repair. There are a number of different ways to do it. This one they did local anchors. Sometimes they'll have a tunnel and they'll put sutures up through the tunnel and try to pull the posterior root down into the tunnel and try to have it heal that way. Okay. Jennifer, what do you think of this case?
So I see the posterior root of the lateral meniscus. It appears intact. There's some oblique increased signal intensity along the posterior root of the medial meniscus, so I'm concerned about a tear.
Okay, so this was another tear. So in 12/18/09, and then the patient came back on 1/29/2010, so a little over a month later. And what we can see, this is that area where there was the tear. This is a tunnel with a little bit of fluid in it. And here we can see that this is a tunnel through here where they had sutures that came up to try to repair that posterior horn. So this was another kind of repair using the tunnels and suturing the root back into the bone. So what is the effectiveness of meniscal root repairs? This is a meta-analysis by Fawcett in the American Journal of Sports Medicine. They looked at 9 different studies, a total of 355 patients. The repair group over time had less osteoarthritic changes, and looking at the number of those who went to total knee replacement, they decided that it was cheaper to repair the meniscus and therefore decrease the number of total knees that had to be done down the line. So they believe that it's cost effective to do meniscal root repairs. Okay, so this is a study in American Journal of Sports Medicine talking about the ISAKOS classification of different kinds of meniscal tears. So this is a pretty busy slide. I'd like to go through each of these. So this is a little bit more organized way to characterize meniscal tears. I don't think anybody in clinical use uses this, but it is something that people are encouraged to use in more of a research setting. So the things that they felt needed to be described for a full description would be the depth of the tear, whether it's partial or a complete tear, and the location. And then they like to use these diagrams for location. This is the right knee and the left knee, and they have zones 1, 2, and 3 through the meniscus itself, as we can see here. Well, this is a right knee and that's a left knee. So that's one area. So they like to have which zone is primarily involved with the tear. And then the radial location, also locations, whether it's the anterior, the posterior, the medial, or the anterior segments of the meniscus in each knee. And then is the tear in the vicinity of the popliteus hiatus? That's if it's the posterior horn of the lateral meniscus. And then they have tear patterns. So they describe tears into 6 different patterns: longitudinal vertical, which would be the kind of a bucket handle tear, a horizontal tear, a radial tear, a vertical flap tear, where basically the tear is in the vertical plane and you have an unstable flap of meniscus coming out here, a little bit like a parrot beak would be one of these type, or a horizontal flap tear where you have a horizontal and then a leaf of the meniscus is flipped up or down on itself. And then a complex tear would have 2 or more of these different patterns within them. And then the description of the quality of the tissues, and that's just how much increased signal intensity was in it. Is it completely black? Is it white? Or is it kind of indeterminate? And then if you have a tear, determine the length of the tear. Finally, 8, if it's a partial meniscectomy, try to determine roughly the amount of meniscus that was removed, how much you could have to estimate what the meniscus should have looked like if it's a normal meniscus and how much tear is gone. Some people try to do a percentage. I think that's very difficult to be very accurate at that. One of the reasons that we'd like to get AI to determine the volumes of the meniscus is whether we could get a more objective, accurate way of making that particular measurement. But right now, we just typically say whether it's small, large, or small, medium, or large. And there's no good definition of what those terms mean. So when they looked at this and they looked at inter-observer reliability to see whether it would be sufficient for clinical trials, they actually found that it was, in their hands, the inter-observer reliability was very good, and that they recommend using that for future clinical trials.
Why is it that it's in Japanese that comes up with this very intensive description of pathology of the menisci? Anybody want to know? Anybody want to tell me?
I don't think this was just Japanese.
No. I understand that, John. I'm just trying to ask the fellows if they know why the Japanese would be the ones to do the job here.
Anybody want to answer that?
Well, the Japanese have 26% more discoid menisci than the rest of the world, except for the Koreans. The Koreans and the Japanese have 26% more discoid menisci. The rest of the folks, 1%.
Interesting. I didn't know that.
I didn't know that either. I just picked it up at Campbell's.
Yeah.
It's an interesting finding.
Yeah. Thank you, John. Okay.
I never heard anybody talk about it.
I've never heard it either. Actually, what do you think of this one?
Okay.
You're welcome, you guys.
Thanks. Now we're looking at the lateral meniscus here. I think there's, I don't know if I'm picking this up. There's some signal in the anterior horn.
A little bit, but remember, in the anterior horn, once it gets close to the tibial attachment, there are multiple strands. So
Yeah.
you often get a signal there, which is normal.
Okay. That looks like some abnormal oblique signal there.
So this is a pitfall. mean, it could be a vertical tear. What else could it be?
Could it be the capsular ligament coming off there?
Well, it could be a Wrisberg's ligament.
Okay.
Which comes across back here, and if you cut the posterior horn of the lateral meniscus right where Wrisberg's ligament comes in, you can have a little bit of fold between the two, which can look like increased signal intensity. So you need to follow this medially to see if this communicates with one of the capsular ligaments, in this case Wrisberg's, and then you've got to go more laterally to see if this goes away, as you would expect if it's just the interspace between the ligament and the meniscus. So that's a pitfall to be careful of. And then there's a variant called Wrisberg's variant, where the posterior horn of the lateral meniscus is only attached to Wrisberg's ligament and not attached to the tibia. It's thought to be a normal variant. I think a lot of these are probably old root tears, which are elevated in this particular case once the root's torn.
There are two types. One attaches the posterior. Well, let me back up. Wrisberg's ligament, the posterior root of the lateral meniscus, which is a discoid meniscus, does not attach to the capsule. It attaches to the Wrisberg's ligament, and that's why it's called Wrisberg's ligament. In flexion, the meniscus looks normal. So when you're doing surgery, you may really miss the boat because the meniscus looks quite normal. And the discoid part actually is not discoid until you extend the knee. Then the meniscus goes forward along with the relaxation of the Wrisberg's ligament. And the treatment for this, if you want to go into it, is complete excision of the meniscus. Campbell's clinic has tried to repair these. They mentioned two cases, do a partial meniscectomy and then repair the posterior horn of the meniscus to the capsule posteriorly. They didn't have a long enough follow-up to say whether it's worthwhile or not. It is not a very common condition, but obviously it's not a very happy condition in terms of treatment. They do say in Campbell's that total meniscectomy performed in Wrisberg's meniscus is quite satisfactory in terms of recovery, and degeneration does not occur until much later. And they can't say much because this is quite new in terms of description. So,
thank you, John. Good. Jennifer, what do you think of this case?
Okay, so we're looking here at the posterior horn of the lateral meniscus. There's some vertical increased signal intensity. So I would be concerned about a radial tear.
Okay. And then what is this signal here, or loss of signal?
There's a ligament connecting to the femoral condyle. I guess I'd want to look at other images, but that could be a displaced meniscal fragment, or it could be a ligament of Wrisberg.
Yeah, this is Wrisberg's ligament going behind the PCL. Humphrey's ligament goes in front of it. And if we look here on the sagittal images, this patient also had an anterior cruciate ligament tear. So what do you think happened in this patient?
So I think they had some type of pivot shift injury where they tore their ACL and also tore the posterior horn of the lateral meniscus.
Right, and you can do that if you have a pivot shift mechanism, because the motion of the bones then causes tugging on Wrisberg's ligament onto the posterior horn of the lateral meniscus, and that can cause a tear. So so you need to look carefully at the posterior horns of both the medial and lateral menisci when you have someone with an acute ACL tear. And this just shows you that meniscus. I'm sorry, this was Humphrey's ligament. Okay, St. Michael, what do you think of this one?
Okay, so on coronal view of the knee, so it looks like we're at the anterior.
Yeah, we're anterior.
So that's anterior, and that's going to be the lateral meniscus.
Yeah.
Because the medial meniscus hasn't made its way around. So this is a root. Yeah. So this is a anterior root tear at the lateral meniscus.
And we'll talk a little bit about ramp tears. So that's in the category of meniscocapsular separations. Here we can see a vertical tear of the posterior horn, primarily involving the inferior surface here, which, as we heard, could be a little bit more stable than the superior involvement, but this would be a peripheral tear, and there's probably a meniscocapsular separation more superiorly. In the setting of an ACL tear, which we have here, this would be one of the varieties of ramp lesions. And so you need to make sure that that's clearly written in the report, because they'll want to look at this carefully at the time of surgery to see whether it's unstable enough to be able to be repaired at the time they do the ACL repair. Here we can see another peripheral meniscocapsular separation back here. And here we can see a tear of the coronary ligament here, as well as a root tear. And then another area where the anatomy is a little bit complex. This is someone who probably had an ACL tear. We can see that there's an impaction injury of the posterior aspect of the lateral tibial plateau. But in the posterior capsular attachments of the lateral meniscus are somewhat complicated, because, as you know, the popliteus tendon has to come down. The popliteus tendon attaches on the lateral femoral epicondyle just below the lateral collateral ligament attachment, and it comes down and has to go from inside the joint space to outside the joint space, and it does that by penetrating through the peripheral attachments of the posterior horn of the lateral meniscus. And if you're medially, what you get is the superior fascicle, right through here. And that's a medial structure because this does not extend laterally, because you have to have a defect in the peripheral attachment to allow the popliteus tendon to come down through. Then there it is too. There's a superior fascicle, and this is the hole for the popliteus tendon. Here's the popliteus tendon after it's gotten out, and now we're starting to get laterally here to the inferior strut. And here's the inferior strut coming down here. There's the popliteus tendon. Here's the attachment of the popliteus tendon. Here it comes down here. It has to go through the periphery of the meniscus to come down to where the popliteus muscle is. And here laterally is the inferior strut, or the inferior fascicle. And then here's the inferior fascicle coming down and attaching here to the capsular attachments. So that's the normal anatomy. You can get fascicle tears. Here's a tear of the inferior fascicle, which is torn, retracted back up, and is somewhat redundant here.
Was there a fracture back there?
There was.
Right Well, that would make it the knee unstable, and that would require a surgical procedure, which I would not want to be the one to do, but it's doable with some difficulty. The reason that meniscus is still sitting up there and not going down with the tibia is the fact that there's a lot of attachments to that posterior horn, and makes it quite stable, and thus the ligaments tear, as we will know when John continues with his lectures. But this is an interesting fracture, and I really don't know how it occurred.
He had an ACL tear.
Yeah, we have ACL tear, but how did that fracture happen? That's a kind of an interesting, interesting forces involved.
Okay. Okay. So let's see. Michael, were you last? Yeah. I think so. What do you think of this case?
Okay, so looking at the posterior horn of the lateral meniscus, looks like there's some increased signal there along the. I guess is that just is that a tear of the fascicle there, the interior fascicle?
So this is the inferior
fascicle, yeah.
It's a little bit indistinct and thick, but it looks like there's a tear where the fascicle attaches to the posterior horn. So this on the lateral side, so it's not really a ramp tear, but this would be.
What would you do with it?
Sorry?
It was not what you would do with it.
Oh. Conservative treatment? Stay off the knee for a while?
Yeah, if you ask me, I'd say the same thing. Treat it. How? The problem is, I think what I would do with this would be immobilize in a cylinder cast and let it heal. I don't think I know how to treat this.
Okay.
Maybe you do. That's why I asked.
I don't.
I don't either. I don't either.
I'm sure there's somebody who would like to put a stitch in it, but I don't know that.
For this little tiny thing, I don't know, John.
Yeah.
I don't know.
Okay. So there's another system by George et al. Looking at lateral meniscocapsular ligaments. Type 0 is normal. Type 1 is a torn inferior or a superior attachment. Type 2 is both are torn. Type 3 or both are torn with 3 millimeter separation in fluid. And they believe that of all of these, only the one where both are torn and you've got displacement should be surgically repaired. But this was about 20 years ago, and people have gotten a little bit more aggressive with surgery since then. Okay, Jennifer, what do you think of this one?
So we have a coronal proton density and fat, looks like T2 fat suppressed images of the knee. I see some peripheral increased signal intensity along the lateral meniscal body. That looks like that could be a tear. The axial images, it looks like there's a peripheral tear of the lateral meniscal body.
Okay. Yeah, so I think there's a peripheral tear. I agree with you. Okay, Michael, what do you think of this one?
So sagittal images of the lateral compartment. I guess we're seeing kind of increased signal at the posterior horn of the lateral meniscus and maybe separation of the meniscocapsular ligament, like there's a little break right there.
It's probably the superior strut, and it doesn't look very good.
No.
Well, let's see. Surgically, this was another meniscocapsular separation with a tear of the superior strut. I think that they treated this at the time of surgery. Oh, I'm sorry. This was something they treated at the time of surgery. The patient went back into the patient was kept out of athletic activities for a while, then went back into sports and re-injured the knee. And this is what it looked like when the patient came back.
So what we're seeing, and it looks like the posterior horn is displaced right posterior to the anterior horn, like significantly displaced.
So the patient on the second injury actually got an ACL tear. This is a typical pivot shift impaction injury on the lateral femoral condyle here. And these damaged capsular ligaments here completely tore, allowing the posterior horn to flip anteriorly against the anterior horn. This patient came in with locking of the knee. Okay. Ashi, what do you think of this one?
How long was it before he played after surgery, John?
I don't remember, John.
Okay.
I think it was a matter of months, though, but I don't remember exactly. It wasn't years.
I'm a guy that it should be a year, no less.
Looking at this, looks like the lateral femoral condyle and tibial plateau. I think the irregularity of the anterior horn is basically like just some increased signal there. Okay, that one, and just looks like there's.
A little more medially, it looks like this.
Oh, okay. Almost looks like it's. Is that an extruded fragment, or is that just? Oh, anterior. Okay, so meniscectomy. Okay.
So what this is, you can get scarring in Hoffa's fat pad. This is actually the anterior horn of the lateral meniscus near its tibial attachment. This is scar tissue, so this isn't a tear. So if you go laterally, it looks okay. If we go back here, and then if we start going medially, you can actually see where the scar comes down and attaches to it. Now, there is a surgeon by the name of Stedman who was a big proponent, saying that what happens when you get scar here, and it's usually after surgery, if it attaches to the anterior horn of the lateral meniscus, the normal lateral meniscus with flexion extension moves about a centimeter anterior to posteriorly. The medial meniscus doesn't move much at all. The lateral meniscus is a very mobile meniscus, and if you have scar tissue which attaches anteriorly here, it keeps it from moving, which means it makes the lateral meniscus more susceptible to damage by the femoral condyles, which are going to keep moving whether the meniscus wants to or not. So he thought that this was a big risk factor for developing a tear of the lateral meniscus, and felt that this needs to go in and be excised to allow free motion of the lateral meniscus. And so this is just something to be aware of, and if you see it, just comment on it in your report. Some surgeons are interested in it and some aren't. It's called anterior interval scar.
Surgery produces a scar, and so does the injury. So I don't think Stedman is correct in his assumption.
Okay.
I mean, the scar, the torn tissue will heal as it did here, and the patient went back to sports, didn't they? Or whatever. Repairing it isn't going to make it any better.
Well, he would excise the scar, which would then allow the to move properly.
when you excise the scar, you get another one.
Yeah, that's a risk.
Yeah, if it's my knee, I don't want that risk.
Okay. Jennifer, what do you think of this case?
So we have two sagittal proton density images here. She's had 4 prior surgeries and pain. There's some blunting of the anterior aspect of the posterior horn of the lateral meniscus. I think this probably represents prior surgery. It doesn't quite approach fluid signal intensity, so she may have some scar tissue kind of there along the posterior horn.
You're talking about over in here?
Kind of along the anterior aspect of the posterior horn. It's slightly irregular, and that could represent prior surgery.
Do you see arthroscopy scar anywhere?
Here, let me go through some more images here.
You should be able to see a scar on somewhere.
She's had 4 prior surgeries.
Yeah, there's some mild heterogeneity of the deep infrapatellar subcutaneous fat. Sometimes that can reflect scar tissue, but it's not as much as I would expect if she had 4 prior arthroscopies.
Yeah.
You're so right.
We see some cartilage loss here. So this was on 10/28/10. Now let's go. You can see where they're at the ACL. Now let's go to a few years later. This is on 8/22/2013. What do you see here?
So she has the screw tracks in the femur. She's had an ACL repair, and there is some intermediate signal intensity kind of along the anterior aspect of the tibia. So I'd like to follow that ACL graft. Sometimes this appearance can be seen with arthropfibrosis.
Okay, so you're saying this looks like scar tissue here in Hoffa's fat pad, and I agree. Here are some other images where we can see that. There's some fluid in and around it, and there we can see that this is a fluid and become much more prominent now than it was a few years earlier. And this was also another anterior interval scar, which was caused by the surgery.
Those can be painful, so you don't want those scars.
In a slightly different location, we'd call it a cyclops lesion. Yeah, right.
Yeah.
Okay. So now, along with partial meniscectomy, often, at least a treatment is if you have Intra-Meniscal Cyst or Para-Meniscal Cyst, they're often treated by partial meniscectomies. We published a paper on about 62 intra and Para-Meniscal cysts back when I was in Santa Barbara. We had about 3 intra-meniscal cysts where the fluid was just within the meniscus itself. These are really tears, and often with MR, or occasionally with MR, we can't actually see it going all the way to the surface, but usually you can see the tear on these at the time of arthroscopy. With current quality machines, we can usually see the communication with the joint space.
The tear, John, can be distal from where the cyst is up to a centimeter, or maybe even more. So you may not see the tear at all. All you see is a cyst, which is kind of interesting. The tear can be anterior, or medial or lateral to the cyst.
Okay. Yeah.
And sometimes you have to do a meniscectomy partial to get to the cyst and remove the tissue that's in there.
Okay. Michael?
Okay, so we have coronal images of the knee. It looks like we have this kind of large cystic structure protruding from the the lateral aspect, or the aspect of the body of the meniscus. Just a large parameniscal cyst.
Yeah, what would you do with that?
With this?
What would you do?
Yes.
Well, I guess it means there's a tear and that there's joint fluid going through the tear, forming the cyst. So, I don't know if you do meniscal repair.
Well, this is a degenerative disease, so repairs are not too good in degenerative disease, and cysts. However, what I would probably do initially is aspirate the fluid from the cyst and needle the meniscus on the side, multiple areas, and get bleeding and then get scarring and hopefully healing. Otherwise, you have to do the arthroscopy and go from the inside. But it can be treated from the outside without doing arthroscopy. I've had some pretty good results on patients that came back to see me 5 years later and so on, after I aspirated the cyst and injected cortisone.
Okay, good. Yeah, so these are Para-Meniscal Cysts. They really do, when you have increased pressure in the joint space from weight bearing, it forces the fluid out through the tear into the periphery, and then the meniscus acts as kind of a check valve. It doesn't allow the fluid to flow back in again. So these can grow to become quite large because of that mechanism. And some people believe that if you do the arthroscopy and do a partial meniscectomy, it opens this up so it no longer acts as a one-way valve, and therefore they tend to stop growing and become smaller, and they tend to become less symptomatic. But I still think that there's a lot of debate as to the best way to treat these.
It's the way articular cartilage works. Are we worried that having a meniscal cyst by itself would accelerate the degenerative process of the knee?
I don't think the cyst will affect the degenerative process for the knee. The meniscal tear might. Yeah. Okay. So, Ashi, what do you think of this one?
So we're coronal T1. Looks like there's increased signal within the body of the lateral meniscus. Yeah, it's a tear. I guess it's extending to. Okay, that's a cyst because it's dark signal there.
All right, then that's a T1 way to demonstrate.
Yeah, it's hard. There we go. There's the Para-Meniscal Cyst. Yeah.
But these are the kind of horizontal degenerative tears which are associated with Para-Meniscal Cysts. Okay. So you just have to look for them.
The way you do it from the inside is you take instrument that it bites. It's like it almost looks like something has teeth, and you go inside the tear, and you just keep nibbling away at the tissue until you get all of it out, and then you might throw a suture or two in there to get the meniscus back together again.
Good.
That's the usual technique for these.
Good, John. Thank you. Jennifer, what do you think of this one?
So we have two sagittal proton density images of the knee. There's
actually T2-weighted images.
T2. There's loculated fluid signal intensity extending throughout the lateral compartment and infrapatellar region. So I'd be concerned that this is a large parameniscal cyst. There is cyst-like change along that anterior horn of the lateral meniscus. So this could be a very large parameniscal cyst.
Yeah. And actually, there's the tear that's causing this large cyst right there. Again, it's a one-way valve, get a lot of pressure, and it just can continue to grow in size because of that, unless you relieve the mechanism.
We haven't mentioned most of these cysts are lateral, and that's probably because the meniscus is kind of more lax than the medial one.
Okay.
I really don't know the reason, but I would guess that.
Yeah, I think that's probably a good guess, John. And here we can see, because the cysts are more common laterally, but the tears are more common medially. So interesting. And here's another very large one that has a kind of multi-laminated, loculated type appearance to it. But these can become quite large. So this was a study in radiology where they looked at outcomes in partial meniscectomy. And they found that those patients that did poor with partial meniscectomy are those who had cartilage loss in the same compartment, marrow edema in the same compartment, meniscal extrusion, joint degeneration, meniscal root tears, and the longer the length of the tear on them are, the worse the outcome. So, this then coupled with other studies that we'll talk about as we go forward in the orthopedic literature have finally gotten us to the point now where generally it's believed that degenerative type tears should not be partial meniscectomized. So what is the role of arthroscopic partial meniscectomy for degenerative tears? This was in New England Journal of Medicine. And here they did a very rare study in orthopedics. They actually did sham surgery. So they took volunteers and they actually did arthroscopy in everyone. And some they actually did a partial meniscectomy, and others they just left the tear alone. Which is amazing. So, Michael, what do you think the outcome was?
Right there, it's no better.
So they looked at 6 months, and well, actually, I'm sorry, they did this differently. They assigned people to either surgery or not surgery. But what they found is that those that didn't have surgery, 30 had some crossover at the end, which was one of the criticism because the patients decided they wanted surgery anyway. But what they still found that there was no real significant differences between those with sham surgery and those who actually had surgery. This is another study. This is in knee surgery sports traumatology. Is arthroscopic surgery beneficial in treating non-traumatic degenerative meniscal tears? They looked at 5-year outcomes between those that had surgery and those who had no surgery, and they found that there were similar outcomes at 5 years. So those that had surgery did not do better. Here's one, the effect of early surgery versus physical therapy in patients with meniscal tears. They say non-obstructive. What this means in their terminology was stable meniscal tears. And they found that PT was not inferior to partial meniscectomy over a 24-month period. What impact does arthroscopic partial meniscectomy have on the development of osteoarthritis? Rashid, what do you think the answer to that is?
Probably increases the risk of osteoarthritis.
So, medial or lateral meniscectomy leads to significant increase in osteoarthritic changes.
One has to consider also the type of trauma that occurred to the knee to cause the tear of the meniscus. If you don't know that part of the history, then you may be quite wrong in assessing the meniscal tear being the problem, and not the injury to the articular surface and articular um, bone. Meniscectomies and injuries and the type of meniscal tears are all important to know. But a lot of the statistics of meniscal tears and surgery, I question.
Okay.
I've seen my own patients over long periods of time done more than one meniscectomy on many of them, and I have my own conclusions of meniscectomies, if done properly without damaging the articular surface and having injuries that did not injure the articular surface, and there's no degeneration, and they do well. If you have articular surface damage, or if you cause the damage yourself, you're going to have problems early on, sooner than later. So when these papers come out, I really question a lot of the results that in conclusion. Sorry to say.
Okay. So here's a recent study that was done in England. And the question is, can marathon running improve knee damage of middle-aged adults? A prospective cohort study. So this had 82 healthy adults, and they had a MRI 6 months before their first marathon was scheduled, and during that 6 months they trained for their marathon. 71 of the 82 people completed their 4 months of training and had at least one marathon. And then they all had a repeat MR scan about 2 weeks after they ran the marathon. Jennifer, what do you think this would do to someone, healthy adults, quite a few of which have some degenerative disease in their knee?
It depends, I would think, on whether they have cartilage loss or intersubstance meniscal signal. I would think if they have any kind of cartilage loss, it's often thought that that's irreversible, and this extensive marathon training would worsen cartilage loss.
Okay, well, that certainly sounds reasonable to me. What they found was that in those patients who had subchondral bone edema, typically from cartilage loss, the actual bone edema improved in this time period. Didn't get worse. I think most people expected that it would have gotten worse. What they found is that there was no significant change in cartilage on the weight-bearing portion of the medial and lateral compartments. The one area that got worse in this group was the lateral patellar cartilage of the patella. And they also had some increased signal intensity in the semimembranosus tendon, iliotibial band, and the prepatellar bursa. An interesting thing is that they found that the menisci were really unchanged. So going out and doing this intensive running, even in adults who have not really been runners before, did not seem to affect the menisci, which also surprised a lot of people.
There are people with total meniscectomies that run marathons. You and I both know one. Yeah. They've run marathons. I frankly don't believe all the papers that have been written about total meniscectomies and partial meniscectomies as to their results, because you don't get to see all the meniscal excisions or surgeries that have been done in follow-up. If you're lucky, you probably only see maybe maximum 75% of them. The rest are either you get literature from them, like a letter or a card. You don't get to see them and examine them, etc. So it can be more of a guessing game as to what's going on.
Okay. So yeah.
I was wondering, I mean, could the improvement in the bone marrow edema, could that just be from muscular strengthening, kind of like around the knee, like if you just had like if that helped with stability or something? Not really sure.
That's possible. Yeah. So the results were that they did have some cartilage loss of the patella, but it was asymptomatic. They had no increase in any knee symptoms in these patients, even though they went through this rigorous process. And their conclusion was that long distance running may actually improve osteoarthritis. Certainly, other studies have shown that motion, like walking, tends to improve symptoms in people with osteoarthritis, but this is the first time running has actually been shown to potentially improve degenerative changes in the knee.
One thing I would mention is that doesn't apply to jogging. It only applies to running. So those are two different activities. I certainly wouldn't put jogging in this group.
Well, but I think most of these people who are probably marathon runners, they basically jogged for the 26 miles.
Well, when they run, John, most of the force is on the ball of the foot and not on the heel, which causes most of the impact to the knee. So there is a give as they run in a flexed knee rather than in a extended knee and a strike of the heel. There's a big difference in that. Jogging, in my opinion, is a very poor exercise for your skeletal system. Any part of it, foot, knee, ankle, back, you name it. Running is an entirely different ball of wax.
Yeah, but you're talking about sprinting.
Correct.
Yeah.
More like sprinting rather than watching people run and striking their heel on the street.
Right. Yeah. We'll talk about the heel strike and that mechanism.
Yeah, I know you well, but I just happened to mention it.
Good. Well, why don't we stop here, and we'll carry on tomorrow. Okay. Thanks, everyone.
Okay. Have a good evening, everyone.
Thanks, John.
Thanks.